class. There are 40 questions on the final, and I'll save some time at the end of the class to give you a blueprint. But it'll cover up through sexually transmitted diseases. So we'll finish this in a little bit, and then when we begin thyroid and adrenal, that'll be on the next exam, exam number 2, which will be on a Thursday, all right, to give us enough time. All right, and then the final exam, of course, will be on a Thursday. All right, so we had finished discussing gonorrhea and syphilis. All right, some highlights. Gonorrhea is caused by a diplococcus. It cannot cross the placenta. All right, however, it can get into the bloodstream and affect joints. There is a type of gonococcal pharyngitis. All right. Syphilis is caused by a bacteria as well, called Treponema pallidum, which is a spirochete, unlike the gonorrhea, which is a diplococcus. And unlike gonorrhea, syphilis can cross the placenta, so therefore, if a woman is pregnant and has syphilis, there's a danger that the infant will develop congenital syphilis, which can have some very serious consequences. Syphilis occurs in 3 stages if not treated. All right, there's primary syphilis, which is characterized by the presence of a primary canker. Then there's secondary syphilis, okay, which is characterized by the presence of condylomata lata and certain other symptoms that we talked about. And then there's tertiary syphilis, which is characterized by the presence of gummas. All right, and basically, if a person's going to die from syphilis, they're going to die from tertiary syphilis because of complications of the heart, the brain, or the bones, or some other organ of the body. Both of those are, the good news for that is both of them are caused by bacteria, so they can be treated effectively with antibiotics. Although we have to worry about increasingly resistant forms, particularly of gonorrhea, so that, all right, we may soon run out of antibiotics that can treat all resistant strains of gonorrhea. Something to worry about, as if you don't have enough to worry about. All right, so now we come to genital herpes, which is a virus. So unlike syphilis and gonorrhea, this is caused by a virus. It's caused by the herpes simplex virus, which is simply abbreviated HSV, and there happen to be 2 types of this. There's HSV type 1 and HSV type 2. All right. HSV type 1, all right, is primarily the culprit, not so much in a sexually transmitted disease as it is in cold sores, but it would be transmitted by kissing. All right. And type 2 is the one that is more likely transmitted by sexual contact and affects the genital regions. Anybody can have type 1, including children, because, you know, it just spreads through kissing. All right. And it's not really a sexually contracted disease. All right, but type 2 is more likely to be transmitted through sexual transmission. However, you know, sometimes type 2 can affect the oral region of the body, the mouth. And sometimes type 1 can affect the genital region of the body. But we're going to focus on type 2, which is the main culprit. All right. After the initial infection, all right, symptoms begin to appear. And these symptoms initially, all right, include fever with the very first episode. All right, malaise, muscle ache, lymphadenopathy. Remember, that word means swelling of the lymph nodes, particularly in the groin area. Dysuria. All of these symptoms may or may not be present. Dysuria, dyspareunia. Remember, that's the term for painful sexual intercourse. All right, and it characteristically produces pruritic. So that would be a word for itching. All right, pruritic, burning genital vesicles. All right. So these vesicles, all right, remember a vesicle from health assessment is filled with clear fluid. All right, they're very noticeable. All right, they usually cause itching. Eventually they break and then they crust over. All right, the initial infection from the time of the onset, all right, from the time of the onset of symptoms until the symptoms disappear, all right, lasts about 10 to 14 days. What happens then is that the virus, the genital herpes virus, is what they call, all right, a neurotropic virus. It gets onto the nerves and follows the nerves to the sacral ganglia, all right, where it takes up home, and lives there forever. All right. So this is one of those viruses that once you have, you can never ever get rid of. It's like the virus that causes mumps, or the virus that the virus that causes chickenpox, the virus that causes AIDS. Okay, once you have it, you never get rid of it. So the initial infection, which we just described, is the most serious, all right, in terms of symptoms. But from that point on, all right, the person infected with herpes simplex virus type 2 is subject to periodic outbreaks, all right, where the blisters form again, the vesicles form again, all right, some of the symptoms occur. But the subsequent outbreaks are not as serious, all right, in severity as the first outbreak. But they are, of course, very annoying, all right? And the person, it varies from person to person. Some people get large frequency of repeated outbreaks. Some people hardly ever get another outbreak. A lot of it has to do perhaps with the stress a person is under. Nobody really knows for sure, although we do know for sure that if a person became HIV positive, for example, and became immunosuppressed, the severity of these outbreaks would increase in both. These outbreaks would increase in both number and severity. All right, to the point that somebody with AIDS who's infected with the genital herpes virus can actually die from it. But this would not be characteristic of somebody with a healthy immune system. The question that's left is infectivity. It used to be, there's bad news here too. All right, it used to be good news, but now it's more bad news. It's funny the way good news becomes bad news. Sometimes bad news becomes good news. Things change. Well, anyway, it used to always be taught, all right, that a person was non-infectious, to another person in between outbreaks. Even though they were carriers of the herpes simplex virus, if it was dormant, they would not be infectious to other people. It would only be during an outbreak, all right, that they would be infectious to other people. All right, so that was kind of good news, However, now studies have shown that that's not true. All right? Although, let's turn a little bad news into a little better news. A person is probably not as infectious between outbreaks as they are during an outbreak. But studies have shown that they can still pass the herpes simplex virus on to somebody between outbreaks, to somebody that's not infected. All right? More bad news. This is really a good news, bad news type of, it depends on what your perspective is, Everything is relative. What people say is good news, bad news, But anyway, the good news used to be that it doesn't kill you, and, there are medications you could take to suppress the severity of the outbreak of the symptoms. All right, you could take an antiviral medication like acyclovir, which has a lot of trade names. All right, and that will certainly reduce the severity of an outbreak. All right, and shorten the duration of an outbreak, so it's manageable. All right, but here's some more bad news. If a woman has genital herpes, and you need to always do a health history for pregnant women, because we get into the area of the effect it may have on the fetus. All right. If a woman has genital herpes, all right, this needs to be known, all right, because if a woman has an active outbreak of genital herpes at the time of a vaginal delivery, the infant could pick up the virus that is being shed by the vagina on its way through the birth canal. Now, this would only be if the woman is having an active outbreak during the time of labor. All right? I guess the good news is this virus does not cross the placenta, but the infant could pick it up, all right, during birth, coming down the vaginal canal, if the woman is having an active outbreak. In which case, then, the infant could become infected with genital herpes. And this is extremely serious because this would be called neonatal herpes if the infant becomes infected. All right? And 50%, 60% of all the newborns who contract neonatal herpes die. Of those who live, 50%, all right, will have serious nerve damage. I mean, you can see those statistics are just staggering. All right? So that's why you have to know, so that, all right, if a woman has a history of genital herpes, she can have a normal vaginal delivery if she's not having an active outbreak. But if she's having an active outbreak, she needs to have a cesarean section. All right, genital warts. So genital warts are caused by the human papillomavirus, another virus. This is simply abbreviated HPV. Now, you know, herpes simplex has type 1 and type 2, HSV1, HSV2. The human papillomavirus has over 100 variations, types of human papillomaviruses, all of which are possible, all right, for a human to become infected with. However, of course, there are some that are more commonly transmitted sexually. All right? And of the ones that are transmitted sexually, there are some that pose a greater risk for the development of cancer. This would be cervical cancer in females, all right, and penile cancer in males. All right. Now, the virus, let me read you some information about this. All right, HPV infection is the most common sexually transmitted disease in the United States. An estimated 5.5 to 6 million cases are diagnosed annually, and approximately 20 million people, all right, have detectable HPV DNA, which is how they can tell if you're infected with it or not. All right, the article goes on. Although most people are exposed to HPV shortly after their first sexual experience, so it's almost ubiquitous, all right, in that sense. In the majority, if you're going to be exposed to it, all right, in the majority of cases, genital warts. See, this is called genital warts because it can produce, and often does, a characteristic lesion. All right, the lesion looks like, it's a wart that has, almost looks like a cauliflower. It's hard to describe. All right, and it can occur anywhere in the vulva or anywhere on the penis. All right, so that's what we mean by the genital wart. All right. However, these warts don't always appear. I don't know if I'm getting it all right, you know, right sequence. All right. Almost, I mean, many people are infected with HPV. All right, I'll read you some more of the statistics. But, all right, some people are asymptomatic. And the good news is that after a few years, their immune system often clears the virus from their body. Yay. All right? It's not like genital warts, which you never get rid of it. However, all right, this is not true for everybody. All right? In other words, there's a variability in this. Some people who become infected get symptoms, which include these genital warts. All right? And, all right, they may, if they get the genital warts usually are a cause of great concern if they're visible because they really are damaging to the body image. All right? Sometimes these warts, when they appear, Remember, not everybody with genital warts gets these warts. Sometimes when they appear, they may disappear on their own. However, there are treatments to remove the genital warts. All right? There are weak acidic solutions that could be applied to it. They could be burned off. They could be frozen off. All right? So there are a variety of methods to get rid of the genital warts. Once again, when somebody has the genital warts removed by medication or through maybe more minor surgical procedures, all right, they may or they may not recur. All right? The danger is primarily a male can get penile cancer, but it's very rare compared to a woman getting cervical cancer. All right? One of the things is there are two varieties. Remember, there are 100 varieties of HPV. There are two types, all right, that, all right, affect the tumor suppressor genes. Remember we talked about cancer? All right, they affect the tumor suppressor genes in the cells and therefore increase the possibility of cancer. All right, so if a woman gets one of the two, remember there are 100 forms, gets one of the two forms that can do this, all right, her immune system may get rid of it. It may not. She may or may not have symptoms. All right? And she may or may not develop cervical cancer, all right, from these two subtypes of HPV. This is what makes, all right, this disease, all right, troublesome, is that, all right, it can lead to cervical cancer, and cervical cancer in some instances caused by HPV can be deadly. That's why, if you've been following the news or you know what's happening, there's now a vaccine available. Okay? And this vaccine, all right, is successful in eliminating or protecting, all right, both a male and a female, all right, against infection with the two subtypes of HPV that cause cervical cancer. Now, the controversy over this vaccine has been the age at which it has been recommended that it be administered. All right? Because, I mean, you can see how ubiquitous, you know, in other words, it's everywhere this virus is, that many people get this virus, don't even know they have it, all right? But it's prevalent in so many people that if you already have the virus, it's too late to get the vaccine. You can't build up your immune system in such a way to protect yourself if you already have the virus. All right, because it's asymptomatic in a lot of people, all right, and because of its ubiquity. I just like to use that word. Isn't that a nice word? You know, my first dog that I had, we called him Ubiquitous. Of course, we never said, Ubiquitous, come here. We always said, Ubi. Anyway. That's why they recommend that the people get the vaccine before they become sexually active. So, you know, when they're 12 or 13 years of age, which right away, you know, causes a lot of problems because people say, well, if we give them the vaccine at that age, we're almost saying we're giving you permission to have sex, you know, that kind of argument. You know, it's out there. All right? But if you get the vaccine before you've ever been exposed to it, all right, then you'll never come down with that two particular strains of HPV. All right. Now, other than the risk of penile or cervical cancer from becoming infected with those two varieties of subtypes of HPV, apart from the body image problems it may cause if you happen to develop genital warts, all right, there's really no other risks involved, and as we said, the good news is often it disappears in a few years on its own.
I read a bunch of articles that HPV actually has correlation with oral cancer.
Yeah, and that's troublesome too. All right, just like you know, if you go out there and you do some education, you know, you go out to high schools, and because you suppose you find yourself in a nursing role where you're doing community education and you're educating, let's say, teenagers to the risks of, you know, to the various risks, health risks. All right, one of the things is, all right, and a lot of adults don't realize this either, is what we mentioned earlier. all right, gonorrheal pharyngitis. It's a real problem. Doctors will tell you they see quite a few cases of it. And the other is HPV can also, all right, be transmitted orally. The thing with HPV is that it can be transmitted by skin contact. It doesn't even have to be sexual contact because it's a type of wart. All right? And therefore, condoms, all right, studies have shown that condoms decrease the risk of transmission of HPV. But unlike every other sexually transmitted disease where you could say a condom is almost 100% successful in preventing the transmission of that sexually transmitted disease, because HPV is transmitted by skin-to-skin contact, all right, a condom may not always be sufficient protection against transmitting the disease. All right, that's something else that needs to be understood. The other thing is, all right, there usually is no risk or danger to an infant, all right, unless, of course, there are the presence of large amounts of genital warts in the vagina. And as the infant comes down the birth canal, once again, like with genital herpes, all right, may pick up a high dosage of human papillomavirus as a result of the birth process, in which case, in some instances, all right, it can lead to a type of infection of the vocal cords, all right, which can be treated, but it's not like, doesn't have a mortality attached to it like the neonatal herpes does, but it is something that needs to be considered. All right. Now, by the way, I just want you to know the name for genital warts, medical term, all right, for genital warts is condylomata acuminatum. So we have condylomata lata for the skin lesions produced by syphilis, all right, and genital warts, all right, the lesions that typify genital warts, the warts themselves are referred to as condylomata acuminatum in this particular case. Chlamydial infections. All right. So chlamydia, so we're up to here now, chlamydial infections. Chlamydia is neither a bacteria nor a virus. It's a chlamydia. Okay? And there are many species of chlamydia. All right? There is one species which has many subtypes to it, which is called, well, I'll write the whole thing out, Chlamydia trachomotis. All right, you just see usually that we're going to see trachomotis. All right, so this is one species of chlamydia that affects human beings. All right, you know, it's out there in the biosphere. All right, some types of chlamydia don't have any kind of relationship with us. But chlamydia trachomotis is a species that, all right, can infect humans. All right, there are 15 subtypes. There are what are called types A, 1, B1, all right, BA, and C. These cause eye infections. They're not transmitted sexually. All right, but they cause eye infections. All right, they're transmitted by to humans usually, all right, from rubbing one eye and touching another person, or they could be deposited in the eye by mosquitoes. All right. So you don't see this in the United States much, all right, but in certain parts of the world, all right, it's a major problem. And what happens is the infants are constantly rubbing and scratching their eyes, and it could lead to scarring and potential blindness. All right. Then there's types D through K, all right, which are the types that are sexually transmitted and are the major problem in the United States and other parts of the world as sexually transmitted organisms. All right, and this is when we talk about a chlamydial infection. This is usually what we're talking about. And then there's types what are called L1, L2, and L3, which produce a much more severe type of sexually transmitted disease called lymphogranuloma. Venereum. All right, this is the major one, D through K. All right? And we know from what we've said already, all right, that this is epidemic, particularly among younger people. All right, remember we read what the CDC has actually even changed its recommendations, that there are so many younger people infected with this that if a younger person is sexually active, they should probably be tested twice a year instead of just once a year, which is their new recommendation. Because remember we said over 70% of the women who get chlamydia don't have any symptoms at all. All right, and so the only way of knowing that they're infected is to have them tested. There's a simple blood test that can be done to determine if they have chlamydia. All right, and then they can be treated. It's easily treatable because although it's not a bacteria, all right, it does respond to antibiotics. All right. The danger is if it goes untreated, all right, it will ascend the reproductive tract in women, all right, and result in pelvic inflammatory disease, which, as we've seen, all right, increases the incidence of ectopic pregnancy later on and or infertility. All right. The symptoms, all right, when they do appear, are similar to those of gonorrhea. So, if the symptoms appear in women, it would include things like increased frequency of urination, dysuria, a vaginal discharge, all right. In men, if symptoms appear, it would include a urethral discharge, dysuria, all right, urethral itching, and in men it may ascend the reproductive tract to affect the prostate and or the epididymis, so it could lead to a prostatitis and epididymitis. Okay, if you are infected with L1, L2, and L3, which fortunately, all right, at the current time has a very low incidence of transmission, it's not a major problem, then you develop what's called lymphogranuloma venereum, which is much more severe, all right, than is C. trachomotis. All right. In this case, this particular type of chlamydia, all right, causes lesions, all right, and all right, these lesions become large, tender. They often involve the lymph nodes, all right, and it causes the lymph nodes to become extremely swollen. So, it's called lymph nodes, lymphogranuloma. All right, it goes beyond just an ordinary lymphadenopathy. An ordinary lymphadenopathy would just be swollen lymph nodes. It causes these lymph nodes to become sometimes the size of ping pong balls, baseballs, grapefruits. I don't think we could use the word basketball. But maybe as large as grapefruits. And, there are several diseases that can actually cause lymph nodes to enlarge so much that they become the size of ping pong balls or baseballs. All right? And when a lymph node is that large, all right, it's called a bubo. Now, that may ring a bell because remember the famous bubonic plague? Another disease which is not sexually transmitted, but which causes the lymph nodes to get really large. All right, and hence it was given the name bubonic plague. Anyway, other symptoms would be flu-like symptoms, joint pain, rash, weight loss. All right, because these lymph nodes are becoming so swollen, they block the return drainage of lymphatic fluid. All right, from the legs. Yes.
This type is treated with antibiotics too?
Yeah, because the good news is it's a chlamydia. Sounds like it should be a name for a new car. And Ford has announced, Chevrolet. Chevrolet has announced its new model, the chlamydia, all right? L1. Yeah, the good news is, all right, that it does respond to antibiotics. All right, but if it's not treated, it's pretty drastic. All right, with those lymph nodes enlarging, it could block the drainage of fluid from the legs, resulting in an elephantiasis, where the legs become the size of elephants. All right, it could also cause the external genitalia to become extremely large. All right, because of the blocking of the lymph nodes. All right. Now, I put, all right, these down. Candidiasis, trichomonas, and bacterial vaginosis. Sometimes these are referred to as minor sexually transmitted diseases. The important point to keep in mind with these is that they are not necessarily transmitted sexually. They may or they may not. If they are transmitted sexually, it's more likely the result of, all right, and these affect women more than men, all right? As a matter of fact, men don't suffer from bacterial vaginosis. That would be a good one, wouldn't it? All right? Because we go back to that idea that there are dotaline bacilli living in the vagina, and they provide a symbiotic relationship that acidifies the vagina, that protects against, all right, bacteria. All right, what they found is that, therefore, anything that disrupts, all right, this normal ecological balance, all right, because you also ordinarily have some Candida albicans living in the vagina, as well as some others. If you disrupt this ecological balance, and that may come about as a result of non-sexual things, like maybe diabetes increases the amount of glycogen available in the mucus, all right? Antibiotics could kill a woman that's taking, say, antibiotics for a long period of time, and is, because of, say, a urinary tract infection or something like that, or some other reason, that may kill off a lot of the symbiotic bacteria, which then allows for that ecological balance to be disrupted. All right, and when it disrupts the ecological balance, it's almost like these are opportunistic infections then, all right, that can take hold. All right, the reason they may be called minor sexually transmitted diseases is because women who have many sexual partners, apart from the other risk factors, which have nothing to do with sex, right, diabetes, extensive use of antibiotics, all right, the other thing is they found that women who have sex with many different partners, all right, that in itself disrupts the ecological balance because of the introduction of new bacteria all the time, all right, and it tends to disrupt it, and that may set the stage for these as well. So the point is, all right, many cases of these are not transmitted sexually, all right, but, all right, sexual intercourse with, all right, many different partners may also be a factor in some women in predisposing them to this as well, all right. So candidiasis, we already mentioned that it's caused by Candida albicans, which is a yeast. All right, it's normally present in healthy people, but again, we go back to the idea that the ecological balance is disrupted. Okay. This produces a creamy, a discharge like cottage cheese. All right, a thick, cheesy, odorless vaginal discharge, and an inflammation that causes itching, burning, and dyspareunia often. All right, so the discharge has often been compared to cottage cheese. The diagnosis is usually made with a wet mount slide. All right, they're looking for a yeast, so they'll take a sample of the discharge, treat it with 10% potassium hydroxide, because that will cause, I don't know how much you remember about biology, it's not a really important point, but yeast have hyphae, little filamentous things coming out, and if you stain a slide with potassium hydroxide, all right, these will become defined, all right, and therefore you can prove that it's a yeast and not a bacteria, and that would make the diagnosis. Whereas if it's any other kind of organism, the potassium hydroxide would not highlight it. All right. Their treatment is fungicidal creams, ointments, or tablets, so there are many of them available, all right? But they have to be, all right, it's not an antibiotic so much as it is an antifungal, it's an antifungal agent. Okay, trichomonas, all right, which causes actually, I think I wrote that on the board more specifically, Trichomonas vaginalis is a protozoa. And again, you know, if the ecological balance is disrupted, it may get the upper hand, okay, and lead to an infection. All right. In this case, it produces often a yellowish to greenish type of discharge. All right, and the cervix may become inflamed, so it becomes reddened. So often on gynecological examination, if the cervix is visualized, all right, because if it's inflamed, it's referred to as a strawberry mucosa. All right, there may also be occasional itching and irritation. All right, this would be treated with a drug called Flagyl. The last one, bacterial vaginalis, or bacterial vaginosis, bacterial vaginosis, can be caused by a variety of bacteria. All right, notice this is a yeast, this is a protozoa, due to upsetting the ecological balance. This would be some other type of bacteria, all right, which gets an upper hand in the vagina because of an upset of the ecological balance. All right, it could be any type of bacteria, but the most common one is called Gardnerella. All right, vaginalis. And this typically causes a fishy or ammonia-like odor or discharge. All right. Now, let me read you some. They send me all this stuff because I'm a nurse practitioner. This is from the Postgraduate Institute of Medicine. Sounds good, doesn't it? I like them because, you know, it's like continuing education. Latest information. Bacterial vaginosis, which is abbreviated simply BV, is the most common vaginal infection in women of reproductive age. Effective treatment is of critical importance as this disorder may lead to a number of sequelae, including pelvic inflammatory disease, neoplasia, mucopurulent cervicitis, and it may facilitate the transmission and acquisition of HIV infection and cause pregnancy complications. All right? BV is characterized by a homogeneous discharge, a fishy odor, pain, itching, and/or burning, and is responsible for approximately half of all cases of symptomatic vaginal infections seen in outpatient practice. In pregnant women, BV is a risk factor for many adverse outcomes. All right, and this is why, again, it needs to be diagnosed and treated in a woman who is pregnant, because if not, it can lead to post-abortion infection, premature rupture of the membranes, amniotic fluid infection, preterm delivery, low birth weight infants, and postpartum endometritis. As many as 16% of pregnant women in the United States have BV. All right? And then it goes on to describe what we described earlier about how there's an upset in the ecological balance. It could be through a variety of mechanisms, sexual or non-sexual. Okay? And it talks about a lot of women who get this may mistake it because of the itching and, you know, the odor. They may just think it's a candidiasis and go to the drugstore and get an anti-fungal agent to treat it with. All right, where actually, because this is not a fungus, all right, it's a bacteria, it needs to be treated with an antibiotic. It can't be treated with an antifungal agent. So there's need for education there, and there's, all right, so that a misdiagnosis, self-misdiagnosis is not made, which can delay getting important treatment. Okay, any questions on sexually transmitted diseases? Okay. Okay, so I want to move now to adrenal and thyroid and adrenal. And first I want to go review with you some of the anatomy and physiology of both the adrenal and the thyroid gland. Then what we'll do is look more specifically at disorders of the thyroid gland, and then we'll look at some disorders of the adrenal gland. And I think we'll probably have a chance to begin diabetes today, which is good news. All right, but anyway. In terms of the anatomy and physiology, we have our old friend that we've already met before, the hypothalamus. All right, up there in the brain, a small piece of tissue, all right, but extremely influential for its size. It's about the size of the tip of your thumb, all right? And it does many, many things. It regulates your autonomic nervous system, for example, so we're not going to talk about that tonight, all right? It is a site where many of your innate impulses, all right, originate. We know that, for example, your impulse to eat or not to eat, your impulse for sex or not to have sex, all right? Your impulse for aggression, to be aggressive or not to be aggressive, all of these things originate in the hypothalamus. All right, they may be modified by upper parts of the brain that can influence it. All right, we know that the hypothalamus is also, all right, responsible for regulating body temperature. All right, we've talked about that before. I mean, it just goes on and on how important this hypothalamus thing is, right? And it also, I said it controls your appetite. All right, interesting. Anyway, the hypothalamus is in direct communication with another gland. A hypothalamus is not considered a gland. All right, it's considered a brain organ. But there is a gland in the brain called the pituitary gland. All right, can you think of another gland in the brain? Dum, 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 dum. All right, your question is, there are two glands in the brain. One is the pituitary, the other is, for $1 million, do you have a lifeline left? You can call Dr. Z. Bling, hello. Hi, this is Meredith, whatever her name is. And then you read me the question. Dr. Z, there are two glands located in the brain. One is the pituitary, the other is the, and I would say to you, pineal. You go, I knew that. But thank you anyway. You ever hear the pineal gland? Right? The pineal gland, we're not going to talk much, we're not going to really talk about it, but before we leave it forever and ever in the dust, never to return to our discussion, let me just reference it for you. All right, the pineal gland is the site, all right, for the production of a thing called melatonin, which has a great influence on your sleep. All right? And the pineal gland, actually, this to me is one of the most amazing things in the world. You can regulate the production of melatonin by the amount of light, all right, that goes into your eyes. I mean, how could light going into your eyes go through your brain and then influence the pineal gland to determine the amount of melatonin and therefore make you sleepy or not? You know, in other words, it sets the basis for what I call circadian rhythms. It's just amazing, but it's true. You know? That's why blind people have much more sleep irregularities than do sighted people. All right? Because they have difficulty in getting the right amount of light in. But anyway, that's all I'm going to say about the pineal gland. Oh, one more interesting thing. This is, you don't have to copy this down. It's not pathophysiology. It's philosophy. Do you ever hear of a philosopher by the name of Descartes? He thought that the soul was located in the pineal gland. I just find that fascinating. You know, isn't that just a piece of trivia? Next time you're at a cocktail party with philosophers, all right, you could out-philosophize them.
Is it the UV rays that do it?
Nope.
It's any light.
It's the lux, all right, whatever that light intensity is, you know, and it transmitted right down special neurotracts that goes right to the pineal gland. Okay, so the pituitary gland is the big one, though. All right, pineal gland is really the small size of an almond or something. The pituitary gland is very big. All right, and it contains two parts to it. There's what's called the anterior pituitary and what's called the posterior pituitary gland. All right, Now, the posterior pituitary gland we're going to come into contact with later on, all right? We've already mentioned one of the things that it produces, but basically the posterior, it's easy, just produces 2 hormones, period. Compared to the anterior, which produces several, all right, it's easier to remember just what the posterior produces. The posterior produces what we've already encountered, oxytocin. All right, we've discussed that already. And the other hormone it produces is ADH, which stands for antidiuretic hormone. So the name tells you pretty much, all right, what its function is. Diuresis is the release of urine, all right, by the kidney. So antidiuresis would be a hormone that would work on the kidney, because remember, hormones work at a point distance from where they're produced. Basically, a hormone is released by a gland, gets into the bloodstream, and travels to a target organ, okay, somewhere else in the body. So in this case, the ADH goes all the way down to the kidney, and, all right, it tells the kidney, do not release urine. Hold on to it. All right, that's what it does, antidiuretic hormone. Now, we're going to see a pattern here when we start talking about the endocrine system. This is basically the beginning of the endocrine system. Adrenal, thyroid, we're going to talk about diabetes, all right, which has to do with the pancreas, which is an endocrine organ too, to a certain degree. All right? We see a pattern when we talk about the endocrine gland, and the endocrine gland, and that is that from a pathophysiological point of view, you get 2 types of problems. It's just logical, right? One type of problem is the gland produces too little of the hormone, and that produces problems. The other pathophysiological problem is the gland produces too much of the hormone. So we always have a hypo and a hyper, all right, problem with any gland, too little or too much secretion. All right, I mean, you can see that already when I just wrote over here, hypothyroidism, hyperthyroidism, right? So we have this hormone ADH. If we produce too little of the ADH, all right, not enough, then we have no brake acting on the kidney, no antidiuretic, nothing to keep the kidney from holding on to the urine. So if we don't have enough ADH, the problem becomes massive diuresis, which is not good because it's like opening the floodgates and just saying, drain all the fluid in the body. Don't hold anything back. And that leads to dehydration. All right? This actually produces, so if ADH is decreased, for whatever reason, maybe a tumor. Tumors could decrease or increase. You never know how they're going to affect the gland. All right? It leads to a disease called diabetes insipidus. Now later, we're going to talk about diabetes mellitus, which is the #1 disease in the world. But there's another type of diabetes called diabetes insipidus, which is number 5,433,000 in the rank of diseases in the world. And I just made that up, of course. In other words, it's very rare. All right? But you may occasionally see somebody, because you're going to be practicing in New York City with 8 million people, all right? You may occasionally see somebody with this rare disease, all right? The reason it's a diabetes is because it shares with diabetes the symptom of massive diuresis, but for a different reason. All right, we'll see. The reason you diurese when you have diabetes mellitus is different than the reason you diurese with this. Obviously, there's no sugar involved in this. So, if a person is having massive polyuria, right, another word for massive output of urine, if they have diabetes mellitus, you put a dipstick in and you're going to find it has a lot of sugar in it. All right, in this case, you put a dipstick in and there's no sugar involved at all. It's just pretty much clear fluid. All right? Now, suppose you get too much ADH. Then the kidneys hold on to the water instead of releasing it, and you become edematous. You get a massive edema. All right? This is known as syndrome of inappropriate antidiuretic hormone. They just use the initials for it because nobody's going to write that out on the chart a million times. Client was admitted with syndrome of inappropriate antidiuretic hormone. Right. That's why we have abbreviations. That's why God invented abbreviations. All right, isn't that nice to know? All right. So anyway, that's syndrome of inappropriate antidiuretic hormone. All right, so we're going to pick up, that pretty much takes care of the posterior. Now, the anterior pituitary, and by the way, the posterior often has a synonym for it. It's often referred to as the neuro, because what happens is there are nerve tracts, all right, here. All right, anatomically there's much more nerve involvement, so it's called the neurohypophysis. It's just a synonym. You could call it posterior pituitary, but if you're reading a fancy textbook or you get a doctor that wants to show off, they might say neurohypophysis. All right, and the anterior pituitary goes under the alias of adenohypophysis. All right, it has something to do with the adrenal gland as well as many other glands. Okay. So now we're going to trace what happens with the thyroid gland first. So let me fill in the thyroid gland, and then I'll erase the thyroid connections because it's too much to put all in one diagram. I don't have colored chalk. In other words, I'll erase the thyroid after we finish. All right. But first, let's talk about the anatomy and physiology of the thyroid gland. The thyroid gland now is outside the brain and in the neck. All right, it's located right here in the neck. All right, and it's made up of two lobes connected to each other by a small piece of tissue called the isthmus. If you remember from health assessment, all right, we talked about that. I'm not going to repeat the same stupid joke I did in health assessment. Don't worry, you could rest assured. You know.
But I remember it that way. You should tell everybody else.
Right. If you have a client with a happy isthmus, you can write down that they have a merry isthmus. But anyway, all right. By the way, these little things these dots, these circles that I drew up there are the parathyroid gland, which, para around the parathyroid gland. Okay, so they are stuck on top of the thyroid. You actually have 8 of them. 1, 2, 3, 4, 5, 6, 7, 8. All right? So the thyroid gland is located in the throat. The isthmus goes right under, all right, the Adam's apple. All right, and then the 2 lobes are on either side. Now, the thyroid gland, not the parathyroid, but the thyroid gland actually produces, all right, I left out a third hormone here that it produces, 3 hormones. It produces T3 and T4. All right. Now T4 goes under the name of thyroxine, and T3 goes under the name of triiodothyroxine. I'm sorry, thiamine. So this is T3, the real name for T3. That's the real name for T4. You can see why they use T3 and T4 instead of writing these things out. All right, so these are the 2 major thyroid hormones, all right, that are involved in doing what thyroid hormones do that we associate with, and that is that they increase metabolic rate, whatever organ they are targeting. And they can target every organ in the body almost. So they could really boost, all right, metabolic rate. All right, that's important to remember. That's just a general idea of what they do. And if you say boost metabolic rate in the heart, what does that mean? Well, it means the heart beats faster. All right? Increased metabolic rate in the digestive system means it increases peristalsis. It speeds things up. All right? The difference between, and I wanted to write this out because I wanted to make a point here in the name. Notice break that up into 3 words. Triiodo. Iodo. All right, that's short for iodine. All right, both T3 and T4 depend upon iodine as part of their molecular structure. And the name of T4 actually hints at the importance of iodine being incorporated into the molecular structure of the hormone. You can't have either T3 or T4, all right, without iodine. Now, as we know, all right, iodine is an element, so your body can't make iodine. The only way you get iodine is ingesting it. All right? So if you have to ingest it, you have to eat foods that contain iodine. And the most likely source of food that contains iodine is seafood. All right? However, in today's world, every time, usually, not always, you can get health food salt, you know. But when you just pick up your diamond salt off of the shelf of the A&P, or maybe ShopRite, I don't know. Where do you shop? Pathmark. Is there a Pathmark in here? In my neighborhood, we only have a ShopRite and an A&P. ShopRite is cheaper than A&P, my wife tells me. But A&P is more convenient, so I would go to A&P. And I spend more for the salt. But it's iodized, right? You know, it's iodized salt. So that helps to make sure, you know, people don't eat a lot of seafood are still going to get enough iodine in their diet nowadays because of the iodized salt, which is everywhere. I mean, salt is in every food that we eat, or a lot of food that we eat. All right? If you do not eat food with iodine, or you don't get it into your body, eventually your thyroid gland is not going to be able to produce T3 and T4, and it will result in a type of hypothyroidism. And we'll talk more about that because that actually causes what's referred to as a simple goiter. All right, and we'll come back to that. All right. The only difference between T3 and T4 is that, all right, they both do the exact same thing, except T3 is more potent than T4. So you don't need as much of it as you do T4 to achieve the same effect. All right? Now there's other hormone. All right, so these increase metabolism of whatever organ they target. This other hormone, interestingly enough, produced by the thyroid gland called calcitonin, has nothing to do with increasing metabolism. It has to do with calcium. So there's a hint right there, calcitonin. All right, it has to do with calcium regulation in the body. And that's where we now talk about the parathyroid glands. All right, they produce a hormone called PTH, parathyroid hormone. All right, that's short for parathyroid hormone. All right, the parathyroid hormone works works in conjunction with calcitonin. So these two are buddies, PTH and calcitonin. And together they regulate the amount of calcium in the bloodstream. So we go back to negative feedback. Here's another good example of negative feedback. I mean, negative feedback occurs in almost all of these cases, but here's another good example of negative feedback. All right. You always have to maintain, all right, a certain level of calcium in your bloodstream. There's a range. All right? You don't want to go below this point. You don't want to go above this point. You want to maintain a certain range of calcium. When something happens, it is in your bloodstream. So if for some reason the calcium level falls below, all right, this mark here, you would develop what's called hypocalcemia, which can be dangerous, could affect your muscles and have some other adverse consequences on your body. All right? So your body kicks in and says, we need to increase the amount of calcium in the bloodstream. All right? Now, where in your body do you store a lot of calcium that it's like a bank you could go to and make a withdrawal and drop into the bloodstream? Right. So your bones are mostly calcium. So when this drops below this normal level here, the parathyroids sense it. They release PTH. PTH goes to the bones and causes enough bone to break down to release calcium into the bloodstream. All right? When the calcium level gets back to the normal range, then it stops. All right? Now think about what would happen if somebody had a disease where they produced, say a tumor is causing them to produce PTH regardless of the level of calcium. You know, you just stick, you know, it's like your accelerator gets stuck. You know, and when you have a pathology, it no longer goes according to the normal rules. So now all of a sudden it's like you're just stuck on the PTH. It just keeps being released, even though the calcium is going up, 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 up. So if that is a disease you have, you're going to get a hypercalcemia, and your bones are going to just melt away. All right, so that's going to lead to an osteoporosis. Now, usually, all right, the calcitonin produced by the thyroid gland works in the opposite direction. It usually works in conjunction with PTH. If the calcium level goes too high, then you need to take calcium. Then you have a hypercalcemia. Then you need to take the calcium out of your bloodstream. And where do you think you want to put it? Back in your bones, right? You know, your bones are like a bank. You make deposits and withdrawals of calcium. All right, so when the calcium level is too high, all right, then the calcitonin is released by the thyroid gland and puts it back into the bones. So usually, if the PTH is increasing calcium, all right, the calcitonin will then take it and put it back in the bones if it gets too high. But if you have a disease, it just overcomes all of these normal checks and balances, all right? It just becomes too much, all right? They used to give calcitonin as a medication to people with osteoporosis. They would give them calcium supplements, all right, and then give them calcitonin, and that would then take the calcium in their bloodstream and put it back in their bones to correct the osteoporosis. Now they have all these other medications, which I'm not really sure how they work, all right? They used to get the calcitonin because they didn't have, back in the olden days, they didn't have genetic recombinant DNA technology, so they couldn't make it from humans, so they had to get it from an animal source. Again, this is patho-trivia, which you might enjoy. And so what was the major, anybody want to guess what the major source of calcitonin was? What animal?
Cows.
No?
Pigs.
No? You'll never guess this one.
Fish.
Fish. Alaska. Swimming upstream. Bears. Plucking them out of the water. Come on. What is it?
Salmon.
Right. For some reason, salmon have a lot of calcitonin. I don't know. I guess they really know the big bones that swim upstream. Okay, now, if we go back to the hypothalamus, the hypothalamus releases a substance called TRF, which stands for thyroid releasing factor. That gets into the bloodstream and travels to the anterior pituitary, which then causes the anterior pituitary to release TSH, thyroid stimulating hormone. Thyroid stimulating hormone then gets into the blood and goes to the thyroid gland and causes the thyroid gland to release T3 and T4, not calcitonin. That's only has to do with the levels of calcium independent of the hypothalamus, but just T3 and T4. T3 and T4 is then released into the bloodstream and does its work, which is to increase metabolism. When the levels of T3 and T4 build up in the bloodstream, right, then negative feedback kicks in. The hypothalamus says, whoa, we have high levels of T3, T4, shuts off the TRF, which shuts off the TSH, which then shuts off the T3, T4. When T3, T4 levels fall too low in the bloodstream, the hypothalamus says, whoa, not enough T3, T4. Produces TRF, which produces TSH, which increases T3 and T4. So it's perfect negative feedback. All right. Now, I just need to fill in what TSH does. All right, because we'll come back to when we talk about goiters. TSH works, thyroid stimulating hormone, by increasing the size and number of follicular cells. So this is, if we look at the type of cell that makes up the thyroid gland, they happen to be called follicular cells. So under the influence of TSH, the thyroid gland makes more cells. And what do you think the follicular cells make? T3 and T4. All right, so that's one way that it increases, remember, because TSH stimulates it to produce more T3 and T4. All right, it also increases the ability of the follicular cells to take up from the blood iodine, because you need iodine to make T3 and T4. Okay, now I'm going to erase the thyroid and just focus on the adrenal, so we'll go through the anatomy and physiology of the adrenal gland. So I'm going to leave the hypothalamus in place and release TRF. I'm going to leave the pituitary in place but erase TSH. I'm going to erase the thyroid gland and the parathyroids right now. All right, and so what I have left is the hypothalamus, the pituitary. This is the adrenal gland, and this dotted line, what this means here is I took the adrenal gland and I cut it in half and showed you what the inside of the adrenal gland looks like. I blew it up because it has an important anatomy in terms of how the tissues are arranged to make up the adrenal gland. But you have two adrenal glands. All right, each one sits on top of the kidney, which is why they're called adrenal. Adrenal, right? Each sits on top of the kidney. Okay. Now let's look at the anatomy of the. Let's take the cross section through the adrenal gland and look at it in greater detail. In the center of the adrenal gland is called the medulla, and these three layers of tissue that surround the medulla collectively is referred to as the cortex. All right? So think of a peach. All right? The pit would be the medulla, and the flesh of the peach would be the cortex. All right? It turns out that the cortex is divided into 3 zones. All right? So all of this is cortex, but it's divided into 1, 2, 3 zones. All right? They're called the zona, the innermost zone is called the zona reticularis. And then I got tired of writing zona out. So the middle zone is called, I just put Z, the zona fasciculata is the middle zone. Fasciculata, F-A-S-C-I-C-U-L-A-T-A. Zona reticularis, zona fasciculata, and the outermost zone is called the zona glomerulosa. Now, where do we come across glomerulus before? Kidney, right? So that's probably going to have something to do with controlling the kidney. Okay, so we have the medulla and we have the cortex. The cortex is divided into 3 zones. The medulla, let's take the medulla first. The medulla produces epinephrine. Now, we've met epinephrine before when we talked about the sympathetic nervous system. It's the main neurotransmitter of the sympathetic nervous system. All right? Remember, the autonomic nervous system has the sympathetic and parasympathetic. I know it's coming back to you now, like a nightmare. All right? And the sympathetic is run primarily by the neurotransmitter epinephrine. All right? Now, the interesting thing about epinephrine is that it's produced by nerves. So, you know that synapse type of thing, that deal with the synapse, right? When the nerve impulse comes down, it causes the release of epinephrine into the synapse. But when you are getting ready for a fight or flight all right, situation. You want so much epinephrine flooding every synapse of your body, and you want it quickly, that there may not be enough stored at the end of the neurons. So you have another reservoir, all right, for a source of epinephrine, which is the medulla of the adrenal gland. This is like no other neurotransmitter. I mean, acetylcholine doesn't have its own little reservoir. It's only produced by the ends of neurons. Dopamine doesn't have its own little reservoir. It's only produced by the ends of neurons. All right? Serotonin doesn't have its own reservoir somewhere in the body. It's only produced by the ends of neurons. Epinephrine is so important for the fight or flight response that you could release large amounts of it into the bloodstream to flood the synapses in addition to what you have already in the synapses from the ends of the neurons. And that's where the adrenal gland kicks in, and you could really, really increase the amount of epinephrine. And the way that's done is there's actually a nerve fiber which comes into the medulla, all right, and sends a little impulse which causes the medulla to release its epinephrine into the bloodstream. Actually, I didn't want to mention it because I've confused myself as to the terminology. I always forget which is which. But maybe when you were reading a book once on pathophysiology or physiology or anatomy or biology or endocrinology, all right, you came across the word norepinephrine. I have to be honest with you. I went to graduate school, almost got a doctorate in biology. Always was reading the word norepinephrine and epinephrine. And I always thought, gee, one must be the British version, one must be the American version. It was only later that I realized one day, when I came across it, that one refers to the substance produced by the medulla of the adrenal gland, and the other refers to the substance produced by the neurons. That's why we have norepinephrine and epinephrine. The thing is, I can never remember which is which. So I don't want to lie to you and mislead you. I mean, you can look it up if you want. But it would be as if epinephrine is what's produced by the medulla, norepinephrine is what's produced by the neurons. It could be the other way around. See, mystery explained. See, it's not the British and the English version. Okay. The cortex, though, is all under hormonal control. All right? This is under nerve control, direct nerve control. The cortex is all under hormonal control. So the zona reticularis and the zona fasciculata, you can lump together. They produce the exact same hormones. They produce the sex hormones because, remember, we've made the point that men have estrogen produced by the adrenal gland, women have androgens produced by the adrenal gland. So this is it. These two zones produce both androgens and estrogens. But what they produce, which is unique and produced nowhere else in the body, for the very first time, ladies and gentlemen, we have the production of cortisol, another really important hormone. All right? We're going to look at cortisol. It plays a really important role, for example, in diabetes. But for now, all right, what cortisol does is basically two things. It increases glucose, and it decreases, all right, the immune response, primarily inflammation. All right, increases glucose, decreases the immune response. Cortisol is a steroid. That's why, if you remember, we've been saying, that when we talked about systemic lupus, right? It's an autoimmune disease. And we said one of the things that you want to do, it would just be logical. If you have an autoimmune disease, then your goal of therapy would be to suppress the immune system so that it wouldn't be attacking your own cells too much. So remember we made the point steroids suppress the immune system. So you would give a drug like prednisone, which is a steroid. All right? It basically does the same thing as cortisol, except it's much more potent. If you have asthma, all right, and you have an inflammatory response in the lungs. Remember we talked about asthma? Or maybe we didn't. Anyway, you have an inflammatory response. We did, because we did that. All right. You have an inflammatory response in your lungs, so you may take an inhaled steroid to suppress that inflammatory response. All right?
What were the three hormones? It was cortisol, androgen,
And estrogens.
Thank you.
All right, the zona glomerulosa produces aldosterone. So now, this is interesting because there are two ways of regulating aldosterone. One we talked about last semester when we did the kidney. All right, the renin-angiotensin system, remember that? All right, and the other is, all right, through the hypothalamic pituitary axis. Okay, so now we have the characters in place. So the hypothalamus releases something called CRF, which stands for corticotropic releasing factor in this particular instance. I mean, when we looked at the thyroid, there was another substance called TRF. So they're both released by the hypothalamus, but we're focusing on the ones of interest for the adrenal gland now. That goes to the anterior pituitary and causes the anterior pituitary to release a substance called ACTH. Adrenal corticotropic hormone. Now notice cortico, adrenal, cortico, cortex. All right? That's why they are contained within those words. These ACTH, when it stimulates the adrenal gland, has no effect on the medulla. It's not the adrenal medulla tropic hormone. It's the adrenal cortico. It only has an effect on the cortex, and therefore the things that are produced by the cortex. So, ACTH stimulates the release of sex hormones, cortisol, and aldosterone. But the really important one is cortisol. All right, that increases in the most amount. All right, and then there's a negative feedback mechanism as well. When the cortisol level builds up sufficiently in the bloodstream, the hypothalamus shuts off the CRF, which shuts off the ACTH, which causes the cortisol to drop. When the cortisol level is too low, it's the old negative feedback story all over again. It causes the hypothalamus to release CRF, to release ACTH, to stimulate the release. Okay, are there any questions? All right, that completes the anatomy and physiology phase. We'll get to the pathophysiology as soon as you return from your much-deserved break. Not enough iodine in your diet, you can't synthesize T3 and T4. So the level of T3 and T4 drops. Okay? Level of T3 and T4 drops. The hypothalamus says, whoa, low. Remember negative feedback? So it releases TSH. Remember, this is what TSH does. It increases the size and number of follicular cells and increases the ability of the follicular cells to take up the iodine. Well, and the thing is, it tries to increase the output of T3 and T4, all right, by increasing the uptake of iodine, but there is no iodine because you have to get it from your diet. So that doesn't work. But what it keeps doing is increasing the size and number of the follicular cells. But it never really is able to cause more T3 and T4 to be produced because that comes from the outside, the iodine. So nothing shuts off the TRF, nothing shuts off the hypothalamus to shut off the TRF, to shut off the TSH. Do you see what I'm saying? So the negative feedback is working, but because you have no iodine to make T3 and T4, you can never raise the levels of T3 and T4. So you keep elevating the levels of TSH, and all that does is it keeps increasing the size of the follicular cells. So pretty soon your thyroid gland gets larger and larger, but you have a hypothyroidism because you're not producing any T3 and T4, a sufficient amount of it. All right? Now, the thing to do in that case, all right, would be to give iodine. All right? If it could be corrected because of a dietary thing, that would be fine. But there is a drug, all right, or to replace T3 and T4 with already formed T3 and T4. All right, you could always give Synthroid, all right, which is T3 and T4. Usually when that goiter begins, it doesn't reverse itself, all right? It doesn't go back to its normal size. You know, back in the 1930s when I was growing up on a farm in Kansas, and, you know, all my neighbors and my relatives would walk around in their bib overalls, you know, because we're all farmers back then. And I wouldn't believe the number of my relatives and neighbors that had goiters, you know, because we lived in Kansas. And if you think about it, Kansas is right in the middle of the United States. There was no interstate highway system. There were no airplanes delivering seafood from the Pacific or the Atlantic coast. We were 1,500 miles from the Atlantic, 1,500 miles from the Pacific, and the government was not iodizing salt yet. So, all right, this was a major, major problem for the majority of people in the 1930s. Fortunately, the Dust Bowl came up and blew away our land, and we had to migrate to California, where I was able to eat lots of shrimp and lobster. And so I was spared. Just kidding, of course. Yes?
Would both thyroids get affected, or just one? Or
Both.
Both would?
Right.
Synthroid is synthetic T3 and T4,
Yeah.
and you would give that for a simple goiter? Or no?
Well, you prefer to replace the iodine, but you could also just give T3, T4.
But I thought it causes high levels of T3 and T4. Or no?
What? Synthroid?
No, forget. Sorry.
Oh, okay. By the way, several years ago, I don't know if it's been surpassed, I noticed that on the internet they had an article about the most prescribed drugs in the world. You know, and the number one drug that was several years ago, I haven't rechecked it since, was Synthroid. All right. So we'll talk a lot more about Synthroid. Now, there may also be a congenital defect that causes the inability to handle iodine properly. You know, the genes can't take it in, so then you have to give Synthroid. Or it may be a side effect of medication. There is a medication that is used to treat manic depressive illness called lithium. So lithium is number 3 element. It's also an element. But they found it very useful to treat manic depressive illness. Now if a person is taking lithium, all right, the body tends to mistake lithium for iodine, you know, because they're both elements. And so the thyroid gland may take up lithium, but of course can't use lithium to make T3 and T4, and that blocks the uptake of iodine. So therefore a person may develop a goiter as a side effect of treatment with lithium. In that case, you need to stop the medication, all right, and use an alternative medication. All right. Thyroiditis is an inflammation, because now we have, yes?
Have you heard of levothyroxine?
No, levothyroxine?
Yeah,
Well, I'm sure it's like an alternative to Synthroid.
I think so, yeah.
Yeah.
Okay.
That's what I would guess it is.
Yeah.
You know? Sure, I'm sure there are different formulations which act, you know, it sounds just like it, but I'm not 100% sure. By the way, there is another important term here. You always want to keep in the bloodstream the level of T3 and T4, just like when we talked about calcium, within a certain range. This range we use the term euthyroid. All right? When you want to say that somebody is within levels of T3 and T4 within the normal range, you could say they are euthyroid. Think about a person now that has a hypothyroid or a hyperthyroid problem. It doesn't make any difference which one. If they're hypothyroid, for whatever reason they're down here, the goal of treatment is to get them up here, right? So the goal of treatment for somebody that's hyperthyroid is to make them, once again, euthyroid. If they're up here with hyperthyroid, it's the same goal of treatment. You want to get them back down here. Of course, in this case, you're lowering the T3, T4 levels. But again, the goal of therapy would be to make them euthyroid. So whenever you're treating somebody for hypo or hyperthyroidism, the goal of therapy is always to make them, once again, euthyroid through whatever means that you use. In the case of hypothyroidism, it's usually supplementation. You know, you add what's missing, iodine or directly Synthroid. It's a little bit more difficult to get somebody who's hyperthyroid back down to being euthyroid. All right, but there are medications that block iodine, that block thyroid synthesis. Okay, and there may be other means that we can talk about. All right, so now we come to thyroiditis. Itis is an inflammation of the thyroid gland. All right, and it comes in 3 versions. You can have acute thyroiditis. All right, you could have subacute, or you could have chronic. And if you have chronic, then it's also called lymphocytic thyroiditis. All right, so if it's chronic, it's also called lymphocytic. Or, I know you can't read this, but I can. Hashimoto's struma. That's one of my favorite diseases. I mean, in terms of names. You know, Hashimoto's struma. It's like you went into an Oriental bakery and said, "I'll have some Hashimoto's struma, please." All right. Easy. All right. Anyway, those are synonyms for chronic thyroiditis. Now, acute thyroiditis is usually caused by an infection with a bacteria. So therefore, all right, that would affect the functioning of the thyroid gland. We don't know exactly how it may affect it. It could do it either way. It could produce a hypothyroid symptoms. We'll talk about what those symptoms would be. Or it could produce hyperthyroid symptoms. It depends on how the infection is affecting the gland. But the treatment for that obviously would be antibiotics. And then the person goes back to being normal. All right, or euthyroid after a while. All right, when you clear up the infection. The subacute is typically caused by infection with a virus. It's not as drastic. It doesn't affect the thyroid gland as dramatically as infection with a bacteria. But here you can only wait until things resolve themselves and the person's own immune system corrects things, because there's no other way of treating a virus. Chronic, on the other hand, is an autoimmune disease. So it can produce an inflammation, but it's not an infection. All right? It's your own immune system which is attacking your own tissues and causing them, all right, to become inflamed. So that would be an autoimmune disease. When this disease takes hold, it always manifests itself early on as a hyperthyroidism. So the client presents with the symptoms of hyperthyroidism. But because it's an autoimmune disease and there's no cure for it, all right, best you can do is hold it in check. All right, eventually it destroys enough of the thyroid gland that the person ends up having the symptoms for the rest of their life of hypothyroidism. So in the early stages of the disease, you might treat it as you would a hyperthyroid, which we haven't talked about how you would treat that yet. In the later stages, you would have to treat it for the rest of the person's life by supplementation with something like Synthroid. All right? Now we come to hypothyroidism per se. All right? And here, what we're talking about is, the first thing is this disease which occurs in infants, all right, and leads to what's referred to as cretinism. So yes, that's a correct term for it. That's the medical term, cretinism, because maybe you've heard people use that term disparagingly. You know, you cretin. You ever hear people call somebody else a cretin? You know?
You say it's called an infant?
Right. Now here's the thing. T3 and T4 increase the metabolism of the organs, but they're absolutely necessary for the growth of the body. All right? I mean, by increasing metabolism of all the different organs of the body, they contribute to the growth and development of the individual. You follow what I'm saying? So it's extremely important that you have adequate amounts of T3 and T4 in utero, and, all right, as an infant, because your brain is still developing. All right, it develops in utero, and it depends a lot upon T3 and T4 to have the proper metabolism to develop properly. All right, and it develops immediately after birth as well. All right. So, if an infant, for whatever reason, all right, is deprived of T3 and T4 during these critical periods of development, it will have long-lasting effects on their brain and certain other parts of their body. All right. Now, it's possible this could occur in utero, in which case, by the time the infant is born, it's too late to really correct it. All right, because most of the damage has been done already. All right, and that infant will be recognized. All right, because of certain facial features. The nose will be broad. Okay, the face will have a certain appearance to it. Plus, they'll have permanent mental retardation because of the way it affected the brain in utero. Do you follow what I'm saying? And they will be short of stature. They will never undergo puberty. All right? Because it affects the reproductive organs too. And because of that, the term that's used to describe them is cretin. And the disease is called cretinism. All right? There's nothing that can be done at that point because it happened in utero. And already things develop that cannot be corrected. The next thing is, it may happen after birth where the infant is born normally, or it may have happened just before birth, and it may not be too late to correct things yet. It depends on where it occurs on the timeline. All right? If it occurs immediately after birth or just before birth, then if you can diagnose it, all right, it's not too late to give supplementation through means of Thyroid, all right, and to therefore prevent the damage from happening. All right, so it's very important, all right, that the early signs of hypothyroidism in an infant be recognized. And if an infant suffers from hypothyroidism, all right, you could see certain things when they're born. All right, if it developed just prior to birth and they haven't developed into cretinoid features yet, they would have probably a persistent physiological jaundice. All right, it'd be very hard to get rid of it. They would have very hoarse, Hoarse. I can't imitate that. Hoarse crying. They would be very sleepy. They would have feeding problems, and they would tend to be constipated. If it's diagnosed, and it's so easy to diagnose it, so you have to do is take a sample of blood and send it off to the lab. Right? And you could diagnose it right away. All right? By the levels of T3 and T4 in the bloodstream. All right, or by the levels of TSH sometimes. Okay, so it could be treated with supplementation. Now we come to adult hypothyroidism, which is an extremely, extremely common problem. It affects women more than it does men, but it affects both. But women are unequally affected; they seem to suffer from it more, and it usually creeps up in a mild manner. In other words, a person doesn't go to bed one night with being perfectly euthyroid, and wake up the next morning and have a severe case of hypothyroidism. It's usually a gradual decrease in the output of the hormone over a period of time. All right? And because the T3 and T4 is decreased, it affects almost all systems of the body. Here are some of the symptoms, all right, that typically present themselves with somebody that's becoming increasingly hypothyroid. They usually complain of sluggishness. They always feel tired. They get a weight gain. All right? They may not be eating more calories, but they're gaining more weight. I think almost every adult, as they get older, develops a degree of hypothyroidism because it's so much harder to get rid of fat when you get older. Take my word for it. You'll see what I mean one day. All right. Sleepiness, intolerance to cold. You see, one of the things that T3 and T4 does is by increasing the metabolism of cells, it increases the release of heat. If a cell is metabolizing faster, all right, it generates more heat. All right. There's more ATP being burnt up.
I had a friend of mine. Is that time when they make a cut in your throat and they take she had a surgery to take thyroids, her thyroids out.
Yeah, I mean, she had hyperthyroid. Right, so in that case, a surgical procedure can be done. You wouldn't want to do that for hypothyroid. She had hypo?
Yeah.
And they removed it? Did she have a goiter?
She gained she used to gain a lot of weight. Her food used to go like a demon in it. So she said she had a surgery, she take her thyroids out.
Doesn't make sense to me.
Another one, my friend had the same thing.
Yeah.
Hypo.
Yes,
Hypo.
yeah.
I don't know if it was blocked or they said that they had to take it out.
Yeah, my friend that worked, they took out hers, yeah.
Okay. Take your word for it.
It's 20 years one.
But anyway, intolerance to cold because, all right, it's cold and you can't can't increase your metabolism to generate more body heat, so you have an intolerance to cold. All right? So on a hot summer's day, they'd be wearing sweaters. Okay? Constipation because it affects the peristalsis. So if you don't have enough T3 and T4, it slows down peristalsis and leads to, all right, constipation. Stiff aching muscles. All right, 12% of the people develop an anemia. All right. Elevation of the diastolic blood pressure with a decreased cardiac output and an enlarged heart. A coarsening or roughening of the skin and hair. So this would be something that the person would notice. All right, the skin and the hair becomes rougher. And of course, weight gain. Did I mention that already? Weight gain?
Yeah.
Okay. So those are some of the symptoms of adult hypothyroidism. All right. Basically, once it's diagnosed, and it's very, as we said, it's very easy to diagnose with a blood test. The idea is to replace, all right, to make the person euthyroid. They'd be down here. All right, so you want to get them back here, so you would give them a replacement thyroid hormone, usually in the form of Synthroid or some other newer formulation or whatever. If you do that, though, all right, you have to, when a person starts treatment with Synthroid, they need to have a series of serial blood tests, all right, to make sure that the dosage that they're getting is rendering them, making them actually euthyroid. Because, you know, you could start them on a dosage that's too small and only moves them up to here. Or you can give them a dosage that's too large and all of a sudden makes them hyperthyroid. So you have to follow that, and usually follow that over a period of time or consistently to make sure that the dosage that they have is right for them, because the body's needs change too. All right, and they may have to have an increased dosage as time goes on.
Is there anything that like increases or decreases, like, you know, glucose, sugar, maybe if you increase exercise, do you need, like, does that affect it?
You know, I'm betting there is out there in the literature, you know, but I don't know offhand. You know, my feeling though is basically no. You know, I mean, because it seems to be something that's just age related. But maybe anything that keeps you from aging. I don't know. You know, it is a very common malady. You know, almost everybody develops some degree of hypothyroidism. All right, as they get older. All right, but especially women is much more pronounced. Usually, it's managed with supplementation. All right. However, all right, and everything, and you render the person euthyroid and everything is fine. The problem is always, though, all right, what could be the worst outcome with this? You know, I mean, could a person die from hypothyroidism? And the answer is yes. All right. What typically happens, all right, is a person perhaps is never diagnosed. all right, and is never treated. Or a person suddenly and abruptly stops their medication. Or a person gets a stressor, such as a really bad infection or cold, all right, and is not, all right, the thyroid medication is not adjusted. These types of things may lead to such a worsening of the thyroid situation, a hypothyroidism, all right, that it leads to what's called myxedema, and that could lead to the death, all right, I mean possible death through what's called myxedema coma. Now myxedema, all right, I don't know, maybe they had some kind of myxedema.
Oh, I think it was, you said it was enlarged, so it might have been, that's why they moved it.
I don't know. But myxedema affects like the face, around the eyes, and it could affect the fingers and the hands. And what you do is you produce a type of edema which is not made up of just water alone, but has, all right, all sorts of mucopolysaccharides spread throughout it. You know, I don't know. Did you ever, when you were in kindergarten or first grade, all right, play with mucilage as a glue? Did you? What did you? When you were in art, did you use Elmer's glue, or did you use these little bottles where you'd press down, you know, and push it out?
Elmer's.
With, pardon?
Elmer's.
Oh, gee. Another cultural discrepancy that we have to bridge. I was just born too early for you. All right. Well, anyway, when I was a kid, they used to have a glue that you know, it came in a bottle. It looked like this. Wait a minute, it looked like this, and the top had a rubber stopper on it like this.
Oh, yeah.
Like a glue stick.
No, it's like...
And you press it down,
Yeah.
and it would be a glue, and it was kind of a brownish color,
And it was like
Oh,
a
yeah.
reddish...
and it was called mucilage.
They
Right.
use it with
Well,
shoes or something?
pardon?
Do they use it to glue shoes together or something?
Maybe, I don't know, but
Yeah.
you know, I didn't have Elmer's glue.
The top would always get stuck together.
Yeah.
Yeah.
Well, I mean, glue is basically, you know, this kind of, you put mucopolysaccharides in water and you get glue. But the body is throwing mucopolysaccharides in water and pushing it into your tissues, so it produces a non-pitting edema, because that glue, like those mucopolysaccharides, when they harden, all right, it's not like, you know, when a person usually gets edema, it's all water, it's squishy, all right? But this hardens because it has mucopolysaccharides in it. So when you press down on it, it's non-pitting. All right, so that's what myxedema would be, is a non-pitting edema. You see it developing around the eyes. All right, it may develop in the tongue. So what happens is a person may start saying, you know, my tongue feels a lot larger. And that's no fun either, because you tend to bite your tongue a lot more. You know? Or their hands get larger or something like that, because, you know. So that's myxedema. Now that would be the first step. That would be a warning sign that, you know, the next step is if they become even more hypothyroid, it may begin to affect them neurologically, and they could be comatose. And if somebody's going to die from hypothyroidism, this is the route they're going to go through. All right. And once they get into a myxedema coma, they lose consciousness from hypothyroidism. It's very hard to resuscitate them. You know. Okay. So hyperthyroidism now. All right, the symptoms.
What do you use to treat this stuff?
Well, you would have to. All right, you would have to give large supplementation of thyroid hormones. Right. Now we come to hyperthyroidism. So here, the symptoms, to a large extent. And have elected president. I promise to put a chicken in every pot. A car in every driveway. A house for every family. And how will I pay for it? Out of my own pocket. Well, anyway. Hyperthyroidism, here the symptoms are often the opposite, as you would expect. All right? So, for example, instead of constipation, all right, in other words, a slowing down of peristalsis, is going to be the increase of peristalsis leading to diarrhea. Instead of intolerance to cold, all right, there's going to be excessive metabolism producing excessive body heat, so there'll be an intolerance to heat. all right? Instead of weight gain, there'll be weight loss with an increased appetite. I always thought it'd be nice if you could just turn that on and off once in a while, right?
I'm sorry, can you
Weight loss with,
Why is it so, I can't, can you take a photo of this? Oh my god, this is awful.
you know, weight loss with an increased appetite with weight loss. You know, I mean, I think that's pretty cool. I like to enjoy that once in a while. But anyway. There may be nervousness, increased sweating, even fine tremors, all right? Palpitations, because the heart could be beating faster, all right, or tachycardia. The one thing it would have in common with hypothyroidism is fatigue and weakness. In this case, your metabolism is just so high that you know makes you fatigued and tired after a while. In the other case, your metabolism is so low that that's the reason you're fatigued and tired. All right, one of the leading causes, I mean, a person could just become hyperthyroid over a period of time, but one of the leading causes of hyperthyroidism is what's called Graves' disease. And in Graves' disease, this is also, just like chronic thyroiditis, this is similar in the sense that it too is an autoimmune disease. In this case, what's happening is, it's an autoimmune disease, Graves' disease. Here's your thyroid gland. Here's your pituitary gland. Your pituitary gland is releasing TSH. Right, here's your hypothalamus releasing TRF. All right, and you're releasing T3 and T4. Over here you have a white blood cell that's producing an antibody. All right, this antibody, all right, is called long-acting thyroid stimulator. Or simply LATS, LATS, long-acting thyroid stimulator. Because this antibody binds to TSH receptors on the surface of the thyroid gland. The same receptor that would be stimulated by TSH is now being stimulated by an antibody, which is a faulty antibody, all right, but it binds to that receptor. So therefore, it acts like TSH because it's binding to the TSH receptor, causing the release of T3 and T4. So now what happens is negative feedback, all right, the hypothalamus says we have lots of T3 and T4, it shuts off TRF, which then shuts off TSH. But it can't shut off the production of T3 and T4 because it's coming this way, from outside the loop. The antibody is not under the control of the hypothalamus, and it keeps producing it. So it keeps pumping out T3 and T4, and there's no way the hypothalamus can shut it off. So therefore, the gland becomes really enlarged. All right? So one of the symptoms you get with Graves' disease, all right, is a goiter. Sometimes Graves' disease, this goiter is called a toxic goiter. The goiter that was over here produced by a lack of iodine was called a simple goiter. This goiter is called often a toxic goiter. You get all the symptoms of hyperthyroidism. And one of the other interesting things that you get, all right, is this autoimmune disease affects, all right, the tissue behind the eye, causing the eye to be pushed forward. When the eye is pushed forward out of its socket, it's called an exophthalmos. All right, so this is what they call the classic, another one of those classic triad types of things. The classic triad of symptoms, all right, that accompany Graves' disease. All right, goiter, hyperthyroidism, and all the symptoms that accompany hyperthyroidism, and exophthalmos.
What's the name of the goiter again? What you said?
Toxic, T-O-X-I-C. All right. Okay, so now, all right, remember, you can have hyperthyroidism without Graves' disease. You just have, for some reason, it's like idiopathic. It just starts increasing the output of thyroid hormone. Or you could have an autoimmune disease like Graves' disease, all right, that could make you hyperthyroid. The treatment for hyperthyroidism is a little bit more difficult than the treatment for hypothyroidism, because the goal for hypo is simply to replace what you're missing, and that's easy to do. The goal for hyper is you have to take away, you have to block the T3 and T4. So what you could do is there are medications that are taken, all right, methimazole, tapazole, all right. These medications can block the synthesis of T3 and T4 at the level of the thyroid gland. All right? So you could try that, all right, thyroid blocking medication. Or, all right, you could go in and surgically remove part of the thyroid gland, hoping you remove enough to render the person euthyroid. The danger here is that you might remove too much and make the person hypothyroid. But then you could treat that with Synthroid. All right? Or you could use radiation. All right? What you can do is implant radioactive pellets right into the thyroid gland. All right? Actually, what happens is the person takes a drink of radioactive iodine. All right? And I'm sorry, it's not because it's not pellets. It's a drink of radioactive iodine. And that radioactive iodine goes right to the thyroid gland and begins to destroy the tissue. All right? If that's the case, then once again, you could become hypothyroid because you could destroy too much tissue. All right, by the way, you know, iodine has a short half-life. All right? So the person would be radioactive for just a little bit, all right, in the neck region. All right, so those would be the ways to treat hyperthyroidism. Okay, so now we come, any questions about the thyroid? Oh, I left out one important thing. How does a person die from hyperthyroidism? How do you die? Let me count the ways. All right, with hyperthyroidism, the mechanism that is very threatening is if a person goes into what's called thyroid storm. So hypothyroidism, the threatening mechanism that can bring about, all right, death is myxedema coma. In hyperthyroidism, the threatening mechanism, all right, that's, you know, it's an emergency situation that can cause a person to die is called thyroid storm. All of a sudden, there is a sudden release of thyroid hormone into the bloodstream, which causes, all right, an excessive metabolism to develop. All right, so what do you think the symptom is going to be when the cells are metabolizing like crazy because of all that excess T3 and T4? Pardon? They're going to burn. Remember we said that when cells metabolize, they give off heat? So your body temperature is going to go way up. It's not unlikely to get to fever of 106, 107. The person has to be put on a hypothermia blanket right away. All right, and they have to be iced down. All right, because these temperatures go way off. Of course, you know, the heart starts tacking away really hard. The blood pressure goes way up. You have to give beta blockers or other drugs to try to slow the heart down. All right.
Could you give?
Pardon?
Calcium channel blockers or no?
Well, beta blockers, yeah, you could, but you know, for some reason, I think beta blockers are quicker. You know, calcium channel blockers have kind of fallen out of favor. I don't know if they're good. Yeah. Right. Okay. And they may give a drug like potassium iodide, which sounds counterintuitive to give iodine to somebody that's hyperthyroid, but if you give a high concentration, you know, that's very high, it's so irritating to the tissue because the thyroid takes it up right away that it actually blocks the output of thyroid hormone because it's so irritating. Okay, so now we come to the adrenal gland, and there are 3 diseases that we want to cover with the adrenal gland. Addison's disease, which is a hypoadrenalism. Cushing's disease, which is a hyperadrenalism. And phaeochromocytoma, which involves the medulla of the adrenal gland. So Addison's disease all right, can be caused by a variety of factors, all right. It may be an autoimmune disease that begins to destroy the cortex of the adrenal gland. It may be an infection of the adrenal gland. And, it could be an acute infection, or there's typically a scenario in which a person was infected with tuberculosis, Mycobacterium tuberculosis, when they were young. All right? And the thing with Mycobacterium tuberculosis, the bacteria that causes tuberculosis, is that you breathe it in, so it goes right to your lungs, and therefore always involves the lungs. But once it gets into your body and takes root in your lungs, it can get into your bloodstream and travel to other organs of your body, therefore damaging other organs of your body. When it damages other organs of your body, it's called extrapulmonary tuberculosis. The other thing about tuberculosis is that the Mycobacterium tuberculobacilli itself can work its way into human tissue like a virus, which is very unusual for bacteria, because most bacteria are too big to find their way into human tissue. They can embed themselves in the tissue, all right, and become dormant. In other words, they can act like viruses, even though they're bacteria. So it's not unusual that somebody developed tuberculosis or was infected with tuberculobacilli. It found its way to the adrenal gland, and it took, refuge in the adrenal gland. The person's immune system probably contained the tuberculobacilli in the lungs, and they never really developed serious tuberculosis, or they recovered from it. But meanwhile, the tuberculobacilli has found a home in the adrenal gland. Now 20 or 30 years go by and the immune system weakens, and just like a virus, all of a sudden that tuberculobacilli becomes activated, which has been living in the cortex for those 20 or 30 years, and slowly begins to destroy the adrenal gland. That would lead to Addison's disease. It may be an hemorrhage that takes place through injury, that could lead to Addison's disease. So, or it may simply be idiopathic, famous idiopathic, no known cause.
But for the TB one, if you're treated for the TB, does it, when it goes dormant, does it get into that system and destroy it?
If you take the full course of, the year-long treatment, probably it'll kill all of the bacteria. But a lot of people are infected with tuberculobacilli that, was never even diagnosed, sometimes. Or sometimes they recover and they didn't have sufficient, it doesn't always, knock out everything. All right. So the greatest symptom is what they call the gradual onset of asthenia. That's just I'm just using that word so you get a shot at another good medical term. Asthenia is generalized weakness. Also nausea, vomiting, and abdominal pain. Now, there's decreased, aldosterone. So that affects sodium reabsorption by the kidney. So that means there's large quantities of urine lost. And the person could become easily dehydrated. There's a decrease in cortisol. So that decrease in cortisol could mean that the person becomes hypoglycemic, because remember we said it increases glucose levels. Which could lead to trembling, nervousness, diaphoresis. And increased susceptibility to stress and infection. It may also cause the skin to turn a bronze color. Now, let me explain that. CRF acts on the anterior pituitary to cause the release of ACTH, but it also causes the release of another hormone from the anterior pituitary called MSH, which stands for melanocyte stimulating hormone. By the way, last week when we were talking about FSH and LH, you remember that came from the anterior pituitary as well. A lot of hormones come from the anterior pituitary. But anyway, here's another one, MSH. So CRF plays a dual role. It not only causes the release of ACTH, all right, but MSH, which goes to the skin cells and causes the increased deposition of melanin in the skin cells. So melanin is the pigment, and the more melanin you get in your skin cells, the darker your skin turns. All right? Now, if you have Addison's disease, you have a decreased level of cortisol. So the hypothalamus increases the amount, remember, because of negative feedback, increases the output of CRF, which then increases ACTH, which goes down to the cortex. But the reason you're not producing enough cortisol is because the cortex itself is destroyed. It's either you're bleeding into it, you have an infection in it, right? You have tubercular destruction of it, so it can't release it. So it doesn't matter how much the ACTH stimulates, it can't release enough to turn that negative feedback off. Are you with me so far? So the CRF keeps being produced. That means the MSH keeps being produced and goes to the skin and keeps causing the skin to darken because that system is not affected. So typically, because this happens mostly in older people, I might have used this, I don't know if I talked about this in health assessment. If I use the same example, I apologize. But, all right, it's January. It's really cold and snowy. Not like this winter. It's cold and snowy out, okay? And an older person comes in complaining of weakness, asthenia. And it looks like he just came back from Florida because he has a tan. Kind of like that woman on that. You see that woman who... Maybe not. Well, some of you know what I'm talking about. That woman that was I don't know what happened to her. She was charged with using her child. And then you look at the woman, she had all of this. Looks like that. And so you say, hey, been to the tanning parlor lately? Old man says, no. Come back from Florida? No, I've been stuck in my apartment the whole day. So you begin to suspect. There it is, a bronze coloration to the skin. All right? From the mechanism I just described. That would be another symptom. All right? Now, if you have Addison's disease, the danger is that, all right, see, these are all, cortisol is a stress hormone, aldosterone is a stress hormone when you're under a lot of stress, and epinephrine, of course. So you need to release a lot of that from the adrenal gland, all right, particularly cortisol in this case. So if all of a sudden you're under stress, you cannot release sufficient amounts of cortisol and aldosterone to compensate for the increased demand by the body, and you tend to collapse from dehydration and really low blood pressure. And you could die from that, all right? It's called an Addisonian crisis. All right? That's why people with Addison's often wear bracelets, all right, saying they have Addison's disease, so that if they're in some kind of emergency situation, all right, the emergency personnel know that they are much more susceptible to stress. They're much more susceptible to hypotension, much more susceptible to dehydration because of the aggravation of the stress. And they need to be treated, all right, with a lot more aggressively for hypotension and pushing fluids. All right. Ready for a little patho of the rich and famous? Okay. This is an exciting feature of our weekly magazine. Patho, the rich and famous. I don't want to give it away too much, all right? So I don't want to say if the president is living or dead. So I only say, what president of the 20th century?
Kennedy.
No, you ruined my fun. Suffered from Addison's disease. And the answer is, you were right. You win the $1 million. John F. Kennedy. Now, think about what I just said about stress. In the 20th century, one of the most stressful things that happened, after World War II, but suddenly, within a small period of time, was the Cuban Missile Crisis. There was a movie Kevin Costner starred in called 13 Days. So you have to watch this weekend, because none of you were born then. I'm the only living person in this room that experienced firsthand the Cuban Missile Crisis. I was just a young kid. I was 10 or 11, and I was shaking in my boots. I was so afraid we were all going to blow up. You ever hear the Cuban Missile Crisis? What happened is, all right, John F. Kennedy was elected in 1960. Maybe it was in 1962 or 63. surveillance planes, all right, were able, flying over Cuba, saw that the Russians were delivering nuclear warheads to Cuba, and they were beginning to build the facilities to put these missiles that could deliver nuclear bombs, all right, in Cuba. Cuba is only 90 miles from the United States. So that meant that, all right, Cuba, all right, and Russia, who had access to these and was paying for them, would have an atomic warhead within 90 miles of the United States. So this was totally unacceptable because this was the Cold War and they could blow us to smithereens and that would be the end of us, right? I mean, probably quicker than we could blow them up. Because, you know, we didn't have any missiles just 90 miles from them, although we did have missiles in some European countries that were maybe too close for comfort for them. But so President Kennedy presented evidence of this in the United Nations. This was not like Colin Powell making the mistake about Iraq. This was photographs and real stuff, right? And, you know, told the Russians they had better move their stuff out and stop delivering it. And the Russians said, "Night." That means no in Russian. So now you see things begin to escalate. What are we going to do? If you don't remove that stuff, we're going to set up a blockade. Right? So you can't bring any more stuff in. We're going to blockade all of Cuba and not let any Russian ships or anything carry any more material in. And then the Russians say, well, if you blockade Cuba, all right, we'll break the blockade. So then the United States has to say, well, if you break the blockade, we have to fire on you. Otherwise, what good is the blockade, right? And then the Russians say, if you fire on us, we'll fire back on you. Before you know it, we're firing nuclear weapons at each other. All right, and that's the end of it. Now, I'm only like 10 or 11 years old, and I'm pretty scared. Right? I mean, I'm going to bed every night shaking. This is the end of the world. I'm going to wake up doing nuclear. Because, you know, we were taught during the Cold War by the good nuns in the elementary school that, you know, they really scared us. I mean, everything, because, you know, they said in case of a nuclear attack, we want you to learn how to hide under your desks. Like that was really going to help us. You know? And by the way, everybody was building nuclear shelters. You know, it was the rage. If you were an upper middle class family, which I wasn't, but if you were upper middle class and you had a nice piece of property, you would dig a big hole in the ground and put in a concrete bunker underground, you know, and stock it with 2 or 3. It's like the survivalists nowadays. Stock it with 2 or 3 years worth of stuff so that you could survive a nuclear attack. And of course, my family didn't have a nuclear bomb shelter, so I knew I was toast. You know. And now, so if you watch the movie 13 Days, it took 13 days before this was resolved. And in the movie, it was very dramatic. I don't know if it was really this dramatic or not. The Russian ship is coming closer to the blockade, and there's, you know, Kevin Costner plays the role of John F. Kennedy, I think, you know, in the White House. And, you know, I mean, we're coming this close to nuclear war. And the captain of the American vessel says, all right, here they come, man your guns. If they get within a mile of us, we have to fire on them, or whatever it was, you know. And the Russian ship in the movie, you know, the tension is building. It's just a movie, you know. They're getting closer and closer, and maybe something like this really happened. And just before he gives the order to fire, the Russian ship jams its brakes on. It comes to a dead stop in the water, averting nuclear war by just a few feet. All right? What happened eventually at the end of the 13th day, all right, is Kennedy promised to remove some missiles from Europe, and so the Russians backed off, and that was the end of the Cuban Missile Crisis. All right? But during that whole 13 days, all right, there's Kennedy. And he suffers from Addison's disease. That's the point I want to make. How does patho affect history? All right? He suffers from Addison's disease, and here he is in probably one of the most stressful events of the 20th century, all right, where we come close to complete annihilation of each other, and he has Addison's disease. You know, I'm sure his doctor was at his side the entire time, pumping him with cortisol. I mean, I'm sure of it, all right? Otherwise, he would have collapsed. All right, from hypotension and dehydration. Yes.
You've seen X-Men First Class?
No.
They have a play on the Cuban Missile Crisis in it toward the end, so you get a kick out. But in that movie, the Russians do go over the line, and then one of the X-Men make the Russians shoot on themselves, so there's no Cuban Missile. But I would. Okay.
Good. I'll have to watch X-Men. What is it?
First Class. It's really good.
Okay. I am proud. I did see Hunger Games. I'm trying very hard to be current, you know. Did anybody see Hunger Games? Wow, you know, I actually liked it. I mean, because I love the Roman Colosseum and the gladiators, and they took that concept, combined it with a reality show, and made a woman the hero. You know, it was kind of like Woman with the Dragon Tattoo. And I was engrossed in it. It was good, you know. Can't wait to see the sequel. But I don't see any of the vampire movies, you know. I haven't got. Oh, I did see Johnny Depp in his Dark Shadows. Anybody see that one? You don't go to the movies enough, you know.
We don't have time. We don't have time.
That was a good takeoff. Oh, anyway, we have to get back. Another thing about Kennedy is that when he was young, he suffered, from ulcerative colitis. So it's an autoimmune disease. And therefore, what do they give you to treat an autoimmune disease, just like systemic lupus? Steroids. Now, this makes a good point. All right? So he's given lots of steroids, which all of the hormones produced by the adrenal gland are steroids. You know, cortisol are steroids, the sex hormones are steroids, aldosterone are steroids. So when you take large amounts of prednisone or whatever it is to treat an autoimmune disease, your adrenal gland, after a while, says, hey, you know, because of negative feedback, no need for us to really produce anything anymore, and the adrenal gland begins to shut down. All right? So because he was diagnosed in the 1930s and they didn't know too much about dosing, he was probably given very large doses of prednisone. And as a result of that, that's how I think he developed, Addison's disease, because it caused the adrenal gland to shut down. So when he stopped taking the steroids, he pretty much destroyed his adrenal gland because it hadn't worked long enough. Which is, if you're giving somebody steroids, which is why you have to taper the dose off to allow the adrenal gland usually enough time to kick back in. But in his case, I don't think it kicked back in. And one of the things that you get with Addison's disease, because you don't have enough cortisol and these other steroids and the sex hormones, is you begin to suffer from osteoporosis. So your bones begin to weaken. All right? Now, remember he became a hero with his PT-109. You don't remember that. But anyway, he suffered a back injury then, on top of the fact that he probably had Addison's disease by that time, which means his bones were weak. For the rest of his life, he suffered from severe back pain. And when he was in the White House, his back pain was very severe. Okay? We don't know, because this was, before we had all this invasive technology to monitor presidents and stuff, how much pain medication he might have been taking while he was actually president of the United States. Sometimes his pain was so bad that they had to carry him off of the plane. But just like FDR, he would never let himself be photographed that way. Anyway, let's move on to Cushing's disease. See what you get here? You get all this background information, Anyway. Cushing's disease is the exact opposite, And in Cushing's disease, you produce too much cortisol and aldosterone. Now if you produce too much aldosterone, it's going to cause the retention of fluid, because remember, aldosterone through the renin-angiotensin causes the reabsorption of sodium. So it's going to cause you to become swollen with edema. So your face begins to swell out. All right? And it's what they call a moon facies. All right? Remember, all that aldosterone is causing an increased reabsorption of sodium. Sodium gets into the intravascular fluid compartment, pulls fluid out of the interstitial, and then the intracellular, and causes an expansion of the tissue. As your face begins to expand and fill up with fluid, it looks like it's turned into a full moon. So this is a characteristic appearance that a lot of people have, and they call it a moon facies. Your blood pressure goes up, because of all that increased aldosterone and that increased fluid. So you get hypertension. Increased cortisol increases the amount of glucose. So, you may develop diabetes as a result of it, because of the excess glucose. It may overpower the ability of the insulin to pull it into the tissue. Cortisol also increases protein catabolism, the breakdown of protein. So that leads to muscle weakness because it breaks down muscle protein, all right? And it causes the loss of certain lymphoid tissue, the loss of collagen, which leads to those purplish striae. Remember, striae are stretch marks. If they're silvery in color, that's normal. I mean, that means at one time a person was obese or pregnant, and now their tissue came back. But if it's purple in color, it means it's a loss of collagen due to the catabolic effect of increased cortisol. All right? So we have hypertension, we have edema throughout the body, we have purplish striae. Because of the increased sex hormones, you tend to get hirsutism. Excessive hairiness, acne, which is a direct result of androgens. So now the treatment for Cushing's disease is, all right, usually it's surgical in nature. The idea is, a lot of times Cushing's disease is caused by a tumor, or maybe idiopathic, all right, but usually a hyperplasia of the tissue or a tumor that causes it. So the treatment is usually removal of one of the adrenal glands. All right, in this case, usually the one that's causing, all right, if it's a tumor, it's just going to be one that has a tumor. Even if it's a hyperplasia of tissue, it's more likely to be one. So it's a removal of the affected adrenal gland, which still leaves one adrenal gland in place, all right, which is sufficient. All right. How many of you would like to supplement your income by writing stories for the soap operas and the medical shows like House? Or the soap operas, you know. All right, well, here's a good one. Again, it illustrates some of the points of Cushing's disease. No, actually, I'll say it's more. Now that I'm thinking of this story, it's more for fake chromocytoma. So let's get the fake chromocytoma, and I'll tell you the story, and we'll finish it up. Well, I will start diabetes, though, if I have time. I'm sorry, I didn't mean to mislead you. Okay, fake chromocytoma. So we've done Cushing's disease, we've done Addison's disease. Now, fake chromocytoma is a problem with the medulla. Both Cushing's and Addison's affected the cortex, but not the medulla. All right, if you affect the medulla, all right, now you have a fake chromocytoma. As background to this, let me point out that we've mentioned this a few times already. There is a thing called circadian rhythms. All right, which things fluctuate over about a 24-hour period. All right, so your adrenal gland, all right, tends to squirt hormones out, including epinephrine, all right, following a circadian rhythm. So your highest level of cortisol and usually epinephrine is around 5 o'clock in the morning, all right, which actually is the body's way of helping you wake up in the morning, all right. Your lowest is about 5 p.m. in the afternoon. All right? I mean, it could vary somewhat. Now the output of hormones goes, and epinephrine goes like this. High, low. All right? Now that doesn't mean that can't be altered. It's not written in stone. It's just a normal underlying rhythm, which can easily be, changed. If you're walking down, because these are stress hormones. If you're over here and you're mugged, right? Somebody mugs you. I mean, what do you say? Well, you got me. I wish you had mugged me at 5 a.m. in the morning when my hormones are at their peak. I could have fought you off. My cortisol, my epinephrine is at its peak. But, you just happened to get me at the right time. How'd you know to mug me at 5 p.m.? Where my hormones are all the way down. No, it doesn't work that way. I mean, this is what happens if you're undisturbed. But if you were mugged down here, your levels will go way up like that. See what I'm saying? I mean, you could respond. So I just don't want to mislead you that way. But if everything else is normal, nothing is stressing you out during the day, which is unusual, right? I mean, you're going to have a normal periodicity, all right, underlying it. All right. Now, a fake chromocytoma is when you develop either a tumor or a hyperplasia of the medulla of the adrenal gland, which is going to result in the excessive output of epinephrine. That excessive output of epinephrine, all right, is going to cause your blood pressure to go through the roof. All right? But what will happen is, all right, this normal periodicity might look more like this. All right? Where the troughs are higher and the peaks are higher, but it will still, even though, all right, you have a tumor or a hyperplasia of the medulla, it will still follow a kind of a circadian rhythm. So your blood pressure goes way up, and then it comes down somewhat. It never comes down to normal, but it comes down somewhat, then it goes way up and comes down. All right, so the person complains of, now, let me step back a minute. Ordinarily, hypertension is what they call a silent killer. All right, so people suffer from just hypertension, they don't feel it. All right, it creeps up on them slowly. All right, and remains elevated, maybe at 150/90 or something, but all right, that still doesn't cause any symptoms. If your blood pressure goes up so to become something like 200/140 or something like that, and suddenly, all right, as it can happen here, it's going to cause a headache. All right, and it's going to cause, all right, that feeling of a headache, and it's also extremely dangerous because a blood pressure that high, especially when it's bouncing up that way, can easily rupture an artery, all right, and cause you to have a life-threatening bleed. But the point is, often the person is aware that there's something wrong because of these headaches, and they're going to get a diagnosis, all right, of what's going on. Okay, so now you take the person's blood pressure. Maybe they're over here, so they have hypertension, all right, but maybe their blood pressure is not off the roof yet. Okay, but you listen to their health history and you want to rule out, all right, is this a fake chromocytoma or not? All right. So it turns out that when epinephrine, which is now flooding the bloodstream and is going to increase again and then come down, all right, when epinephrine is broken down by the body, it produces a waste product called vanillin-mandelic acid. VMA, vanillin-mandelic acid, which then shows up in the urine, so you can measure that in the urine. All right. So you could do a CAT scan, because if the fake chromocytoma is, causing a hyperplasia or a tumor, that adrenal gland will probably be larger. But that's extremely expensive to do, and you want to do a screening test first to see if you're in the right ballpark. So what you would do is order a 24-hour urine, and you would check off that you want the lab to measure the level of VMA over a 24-hour period. So over a 24-hour period, there's going to be several of these, this is going to fluctuate, all right, it's going to go up and down, and by the end of that 24-hour, you've collected all of the urine, so you know what the total amount of epinephrine was by the amount of waste product it produced. And if the VMA is extremely elevated over normal, you have, all right, the definitive diagnosis of fake chromocytoma. Now you could do a CAT scan to see which of the two adrenal glands is affected, because the idea is you're going to have to go in and remove the affected adrenal gland. Make sense? Now we can get down. I want to show you how you could convert your pathophysiology notes into, all right, extra income by being a writer on the side. All right, all you need is a little imagination, and you could get some of this stuff, all right, into great scripts. There used to be a show on TV, because I remember this show. It was called Chicago Hope. Again, none of you probably ever heard of it. It was like many, many years ago. And it was one of these hospital-based medical drama shows, all right, which was kind of soap opera in nature. So I'll never forget the script, though, because I just thought it was the coolest thing. It's like, I wish I had written Hunger Games, because I love the Coliseum and Gladiators. If I had just thought of combining that with reality shows and making the woman the hero. Think of it. But anyway, here you go. All right, in this soap opera of a hospital drama, a nurse is jilted by her physician lover. All right? So, you have to have motive. And of course, always, relationships, being jilted and stuff like this, and revenge and stuff like this. So she wants to get revenge on this physician who totally ignores her now. The physician becomes a member of the board of trustees and a part owner of this hospital. I don't know how that works, but anyway. All right, so one day she goes to the emergency room and her blood pressure is off the charts. All right, and I like this show because they followed this. You see how you'd be writing this now? All right, all you added is the plot. All right, but you have all the background to fill in the details here. So they do a 24-hour urine. Her VMA comes back very elevated. So they suspect she has a fake chromocytoma. Right? So they now order a CAT scan. And the doctor is not the doctor that's involved in the board of trustees and is going to lose all of his money. I gave it away here. All right. But the doctors are arguing, all right, over which of the adrenal glands is enlarged. But they have the VMA is elevated. They have the health history, the physical exam. They know that she must have a fake chromocytoma. So one of these adrenal glands must be enlarged. This is like human nature. It's true. So they're looking at it, and they both look the same, but they have to figure out which one is enlarged. So they finally all agree it's this one. Right? So they go in and they operate on her. All right? And the biopsy comes back, and the adrenal gland is perfectly normal. And they go, uh-oh. We took the wrong adrenal gland out. And you can't put the adrenal gland back in, once you take it out. So now we're going to take out the other adrenal gland, and this is iatrogenic, because now she's going to take cortisol and epinephrine for the rest of her life, which is real pain. She's going to sue us up the kazoo for negligence, and she's going to get multi-million dollars, and it's going to cause the hospital to go broken under. All right. So one of the doctors walks in to tell her the bad news, and that's when he catches her injecting herself with epinephrine. Get it? She knew that if she elevated her levels of epinephrine, her VMA would be higher. She would have all the symptoms of a fake chromocytoma. Right? And she was willing to have her second adrenal gland taken out just to get, I don't know, do you think this motive really holds water? And just to get even with this boyfriend that had jilted her. Isn't that amazing? You like that story? I mean, you see, I wonder how much those writers got paid. I was once, I once acted as a consultant for a soap opera. I got paid a nice check, and all I had to do is to say, they called me up to ask me, all right, because I used to be a CCRN nurse. How would you treat somebody in the critical care unit whose blood pressure is falling? And I said, hook them up with dopamine. All right. They wrote me a check for a considerable amount of money as a consultant. It was the greatest thing I ever did in my life. Unfortunately, they never consulted me again. I don't know what happened. All these soap operas got a business. That's the whole problem. Okay, go over the test, right. If you take your tape recorders and take them off. I just wanted to say, though, that I just wanted to add two things about the prostate gland before I go over the test. They must be important items that I mentioned. All right, if a person has BPH, one of the symptoms, benign prostatic hypertrophy, one of the symptoms is, often they develop an increased incidence of urinary tract infections. With regards to prostate cancer, one of the things that I wanted to say is that the incidence of prostate cancer is much higher among African American men, all right, than among other groups. Okay. Now you can turn, if you haven't already, turn your tape recorder off. Having said those two things,